Good morning, everyone. I'm Stefan Harrer from the Digital Health Cooperative Research Center, and I welcome you all to a very exciting panel. It's an exciting panel because we have a lot of exciting panelists on stage here, a very eclectic selection of stakeholders in the AI and clinical sector. Let me just introduce everyone real quick. So we have Farah Magrabi over there from the Australian Institute of Health Information at Macquarie University, and she's also the Chair of Safety and Ethics at the Australian Alliance for AI in Health. We have Johan Verjans here, the Deputy Director of the Australian Institute of Machine Learning, and particularly the medical analytics arm of it. We have Therkelsen-Terry here, the CEO of Australian AI quantum computing powerhouse Kelsen. And we have Daniel Yang here from the Gordon and Betty Moore Foundation, Program Director there. And thank you, Dr. John Halamka from Mayo Clinic. He's the president of Mayo Clinic platform. Mayo Clinic doesn't need a introduction. John is a trailblazer and mover and shaker in adopting responsible use of AI in clinical practice. So,
hey, but more importantly, I'm Daniel's best friend. Good to see you, sir.
Right. Thanks a lot for joining us from the US virtually. And you probably can't see this, but you're in front of a packed audience here. So we're very eager to have this discussion and hear what everyone has to say. Now, generative AI is something that doesn't need a lot of contextual introductory information. It's all around us. There has been, of course, a large hype. We have seen everything from doomsday scenarios to the solution and panacea to everything in between. So that is something that I would like us to unpack a little bit, pull it down onto a pragmatic, practical level where we can all understand the real opportunity and the risks and how to work all of this through reasonably and responsibly and efficiently. I'd like to ask around the table here to get a pulse check on what you think, from your perspective, what do you think the main changes will be that generative AI will bring to your particular neck of the woods and what impact that might have. I also want to ask you that all individually because I don't want to have everyone sort of say the same things, and I'm sure there is very specific thoughts that you have. So perhaps start with Johan here. So I just said that AI is often heralded as the panacea of everything, right? And can solve anything under the sun. What were your thoughts on this from a medical perspective? Is this really something that will do all this magically, or are there intricacies that we need to watch out for?
Thank you for the invitation. It's an honor to be here. Yeah, it's math, it's not magic, so we have a long way to go. But I think, I have a clinic. I'm a cardiologist, practicing cardiologist, and I do a lot of non-cardiology stuff half-time. And a lot of the work I do can be automated. Don't put it in the newspaper, but cardiology is not that hard. It's about the 10 to 20%. It's like a pilot, right? It's about the exceptions and about human contact and things like that. That is the high-level impact, I think. Speaking in the context of generative AI, it will sort a lot of that easy stuff, the 1 second stuff for us. Everything you can do in 1 second can be replaced, right? And on the other hand, if there's too much data, we cannot pack it, quickly summarize, so that will help us. So generative AI will help us prepare stuff. But most of the research we still do is actually still on pattern recognition, classification of disease versus non-disease, because we're not even close to personalized medicine yet. Everybody still keeps on using it. I'm starting to get a bit itchy about it, that we're still in the middle of evidence-based medicine, and there's no way of getting out soon, right? And we need to crawl out, and there's a few good use cases, I have to agree, but still, my clinic is in the Middle Ages. Nothing is digitized. I have a database that I need to click through extensively, and this whole conference is around that, but it's not in my clinic. So that's a huge gap. So generative AI will help us with a lot of things, and I like the fact that even the Microsoft leaders were a little bit surprised by how well it performed, and but it doesn't think. So that's important. It will make mistakes, and that's why we need a lot of time to get into health.
We'll get to that surprise element in a second down the road. So thanks a lot. Johan speaks a lot to the efficiency and using that technology in clinical practice. John, trust is the foundation for using any sort of technology in a high-risk, high-impact environment such as the clinical one. From your experience, how do you see the foundation of trust? How do you see that evolve as we go through a very heated, a very fast-evolving cycle of calls for stopping everything to calls for opening the floodgates? What's the right way here to build the foundation of trust so that this technology can actually live up to these expectations like Johan just described them?
What a great question. And again, an honor to be here. Think of generative AI as the best high school student you've ever seen. It speaks 100 languages. It writes poetry. It just has no knowledge of healthcare. So if you take foundation models, such as those created by OpenAI, Microsoft, Google, or even the open source models like Llama, they need to be fine-tuned. And so the role of Mayo Clinic and others who are expert is to take these high school students and turn them into at least intelligent medical students by teaching them and fine-tuning the underlying data sets and parameters inside these models. Now, the challenge, of course, is measuring quality and accuracy on generative AI is pretty hard. So the Gordon and Betty Moore Foundation has funded an initial effort to measure quality and accuracy in predictive AI, and we're making a lot of progress in that regard because you can measure it against ground truth. With generative AI, I'll be honest, I think what we have to do is pick use cases where the likelihood of harm is low. Write an appeal letter to an insurance company, help summarize a medical record, or potentially help you with creating documentation. We are still a ways away from helping you with diagnosis and treatment.
That's a very good view onto how to assess the impact and the risk of using generative AI in real use cases. And that segue, I'll pick up on that. Daniel, what are consumer-centric use cases of generative AI? And I would like to ask you, like there's generative AI and it's being essentially taken as a synonym for everything AI, but there are use cases out there. The FDA publishes a list of approved AI-powered software as a medical device services ongoingly, right? So there is a legacy here. Can you talk a little bit to the consumer-centric use cases of generative AI, especially with regards to what's already out there?
Sure. So, as I mentioned in the presentation earlier this morning, we work on diagnosis at the Moore Foundation. And I don't know how many of you have ever Googled a symptom that you were worried about. I think Google receives hundreds of millions of internet search queries around symptoms a day. Apparently 100 billion hours of videos on medical advice are watched on YouTube every year. And so people are going to these internet search engines and social media sites for health information to make sense of their symptoms. They've been doing it probably as long as they've existed. And so when I think about ChatGPT and these LLMs, it's not a matter of if. Patients are already using it. And if you haven't been, it's better than Google, particularly GPT-4, which you can either do via Bing or you have to, there's a paywall for it. But it's really interesting to compare the use of, let's say, ChatGPT versus Google. One is how they work. The underlying algorithms are different. If you ever search a symptom on Google, it really, to me, reflects more psychology than epidemiology, because the algorithm tries to identify click-through rates. It uses that as a proxy for accuracy of result. And so if you search muscle fasciculation, muscle twitching, the #1 search result that you get from Google is ALS, which is not the most common cause of muscle twitching, but it's the most common cause of things that freak people out with muscle twitching. But if you were to actually search those symptoms on ChatGPT, the whole notion of what we consider Bayesian reasoning, Google doesn't do Bayesian reasoning, and it doesn't for a few reasons. One is people don't put complex contextual information into Google necessarily. I guess you could, but just a quick thought experiment, or a quick experiment, I was on ChatGPT, I said, I'm a 27-year-old woman with nausea, vomiting, and fatigue. What do I have? And its first diagnosis it gave back was pregnancy, which, it's probably pretty likely, or wouldn't be an uncommon diagnosis. And if you replace that with, I'm a 67-year-old woman with nausea, vomiting, and fatigue, its reaction was dehydration, #1, and 2, med effect. Now, that's, I don't know if we're talking about thinking, but it impersonates a sense of Bayesian reasoning, pretest probability, differences in ages, comorbidities leads to different probabilities of different diagnoses. So when you compare it to our existing internet search, I actually think it's a stepwise improvement, particularly if you compare it against having access to no healthcare. And so we're here in Australia and we're in the United States. We're privileged. Many people are privileged to have healthcare. If we're talking across the globe or certain populations in the United States, they have very limited access. So we're going to talk about some of the risks and the concerns, I'm sure, but I actually think that it is an incredibly powerful and useful tool that people are using today that is giving them useful information to make decisions about their health.
This sounds like, and probably is, a real great opportunity statement for those who build and provide these tools and these algorithms. Nick, from an industry, startup enterprise perspective, Sam Altman got up on stage at my alma mater in Munich a couple days ago and asked about the opportunity that this time presents to developers, technologists, industry, to really jump on the bandwagon and leverage that. He spoke of a Cambrian explosion of opportunity. Do you subscribe to that? Do you experience that?
Look, I definitely subscribe to that view. Picking up on John's point, actually, which was that there's a range of use cases, and they kind of start from the benign and go through to the science fiction. And when we have these discussions, particularly in the context of generative AI, we do tend to pull towards the science fiction. And the popular narrative out there doesn't dissuade this. It encourages this, all the doomsday talk. And just for the reference, I'm an AI maximalist. I welcome our new overlords. But the fact is actually that many of the use cases that we're going to see generative AI be used for are quite benign and kind of fit within existing product experiences. And so I think we focus a lot on its ability to generate, because it's in the name, but what we actually ignore is its ability to interpret, its ability to follow chain of reasoning, its ability to move through multiple steps in a goal-orientated way. These are things that have kind of, we've ended up with as capabilities in these models, not by design. And in fact, if you talk to many people, as I do at OpenAI and at Google, the answer is we don't really know why they can do these things, but we know it can do these things. And so if I take, we're all in healthcare, we've all seen the natural language processing, of the last couple of years. We started with support vector machines and they really sucked. And then we went to some basic neural network stuff that was also really bad. And over the last couple of years, it's got marginally better, but it still sucks, right? You still get this document and you ask it what's the diagnosis of the patient, and in that letter we might talk about the family history, and so there's a bunch of diagnoses there, and there might be a bunch of excluded diagnoses and differential diagnoses, and so you get this list of diagnoses and none of them are actually the diagnosis you're looking for, because actually you've got to be able to read and interpret that text in a different layer. Exactly as you're saying, Daniel, in a different cognitive ability than looking for a particular mention of an entity or a word. And so what we see is that actually NLP is dead. Because why would you train a model to recognize entities when you can just put a document into a generative AI system and ask it to extract a very specific piece of information? I don't need to train it. It has far better knowledge of the context, and it's far more robust to data set shifts. So when the data comes through and it doesn't look like what it's been trained on, They are very, very good at adapting to that. So I do think that whilst there is some amazing top-level experiences that people are going to see, what the big change is going to be is actually how we build and deliver software to a whole range of use cases. And some of those will feel very benign and boring, but actually our ability to solve those problems and solve them reliably and scalably will be transformational.
So you're excited. You're pragmatically
Incredibly
excited.
excited.
That's wonderful. So channeling that excitement, right, into translating it into building software, into building solutions that are safe, that create this user experience, is an art in itself. And how we do this is not at all clear. The technology proceeds and charges ahead at lightning speed. Evidence that would support building regulatory frameworks, guidelines, not so much, right? There's a gap here. From a safety perspective, what would you give as pragmatic, hands-on advice to those who think about using generative AI technology, integrating it, building software in a clinical environment, so that what comes out of it at the other end delivers all this value and does it in a safe way?
Yeah, look, thanks very much, Stefan, for having me. Look, I'm really excited about the potential of the technology, particularly the user interaction part of it, right? So you're not sifting through information, you actually get an answer back. And that is a boon whether you're a consumer looking for information on the internet or you're a clinician sifting through records, right? But I think we need to just temper the conversation a little bit. So first and foremost, we need to distinguish the clinical grade systems that are approved through regulatory agencies like the FDA and the TGA from generative AI, right? So we are not seeing generative AI systems being marketed as medical devices. And so I think we need to be really careful and make that distinction, because the devices that have received regulatory approval, well, we're saying we have confidence that they're safe enough that we're going to test them and use them in our clinical care, yeah? And so as far as generative AI is concerned, I think there's still, a long way to go. Like John was talking about, there are organizations that are starting to fine-tune general models and train them specifically for clinical purposes. And I think there's a lot of work to be done there in terms of defining the use cases. So you're going right across the spectrum from, low-risk applications through to high-risk. But even if you talk about consumers looking for information on the internet, well, I love the aspect that generative AI can give you an answer, but I'm still, sometimes wondering, well, where is it coming with this information from? And so if I cannot tell whether the information is coming from Mayo Clinic or Health Direct, well, what confidence do I have? And so I think there's, the work that lies ahead is in terms of untangling how do we, train these AI on data that we have confidence in, and so whatever they're singing from the song sheet that we want them to sing from, essentially. And then on the other side, how do we train clinicians and consumers to be able to at least be able to verify that information? Because we know they're not going to be 100% accurate.
Absolutely. And I think, so you point to the elephant in the room, right? Risk came up a few times in the answers. John, you with the Coalition of Health AI, which is a big consortium that incorporates big tech as much as clinical institutions, you've recently launched a consultation paper that speaks to assessing risks and gives some pragmatic pointers to how to do this. Can you talk a little bit to what you see as the major risks, and possibly give a pragmatic guidance to those who are seeking to apply this right now with what we have at hand right now, and get their hands dirty in a safe way and explore what this technology can do in their respective field?
Well, happy to do that. So I think all of us want to deploy algorithms that are fair, appropriate, valid, equitable, and safe. Those terms I just mentioned spell the word faves. So let's all decide that AI algorithm there are faves. To do that, what we have done with Gordon Betty Moore Foundation and now 200 different organizations in government, academia, and industry is to find a blueprint for the assurance of AI. Now, this is focused mostly on predictive AI, saying, how do you curate the data? How do you develop the model? What are the inputs, the outputs? How do you validate the model against different data sets and then publicly present the statistics? How does that model perform in various subgroups? Can it be trusted? How do you monitor it over time? You'll see a lot of this notion of testing laboratories and public reporting for transparency instantiated into regulation in the next couple of months by FDA and other agencies. But generative AI, as we've been chatting about, is a whole different kind of problem because it's probabilistic, not deterministic. A quick case. Our chair of cardiology asked ChatGPT, I've got a patient who had a recent open heart surgery with a sternotomy and needs a pacemaker placed 1 week later. Is that safe? And ChatGPT said, well, there's actually been a clinical trial with 5,000 patients, and here are 2 references in the Journal of Clinical Electrophysiology. It's completely safe. The study was never done, and the journal does not exist. And that's a problem. It's fabricating the information in a very credible way, and that's very hard to measure. So how about this? For the moment, yes, Coalition for Health AI has a blueprint for predictive AI, but at best we'll have use cases for safe use of generative AI until we can measure its quality.
So that's fascinating, right? Essentially what this means is that human supervision and validation and input is absolutely essential in applying these technologies in a reasonable way. Question I have for you, Johan. So word on the street is that essentially generative AI development, the frontier of it, is very much dominated by a few big tech players who have the means to provide these immense compute resources, get their hands on the data that's needed, and do all this. That's not exactly how you build a diverse developer community. And as we've just heard, having a strong clinical representation in the development of these models is absolutely integral to make them safe and useful. Do you see that academia and research that's not necessarily connected to big tech providers or their proxies will in the future have a word in how and a seat at the table in how these tools are developed?
I think so. I think we have to, because we have been developing these things. I was writing grants 4 years ago on talking to my computer and extracting imaging data, and it's called medical visual question answering. And now it's suddenly called ChatGPT, but this has been going on for a while. So I think there's the fine-tuning. Once you want to fine-tune algorithms, you have to know how they work. And the surprise that, maybe it's not surprising that just adding a whole heap of data to just not so sophisticated algorithms does a really good job was surprising to a lot of people. And then this side effect that was just described with fake, it shows exactly that. So university and research, they have a role in fine-tuning and helping regulate that. I'm a little bit afraid that this whole wave has generated now a conservative policy throughout the world, because if I'm a policymaker, I probably would start out conservative, and that inhibits me with both my heads, the research head and the clinical head. So we will have a role, but compute and data is just not something a lot of small companies or universities have. So the big tech will continue to dominate. That's my prediction as well. But they will ask for help. They knock on our door regularly, so we should be able to be part of it. But sometimes you feel they ask you just to be nice, right?
Space to watch, right? And it's something definitely with a lot of work to do around diversity. A few, comments on the regulatory landscape. We see a lot of activity around the EU AI Act, which is probably the domineering piece of legislation coming out right now. We had the U.S. Congress hearing where Sam Altman and others testified. But there is a consensus that regulation needs to catch up. What does smart regulation look like to not stifle innovation, but at the same time to explore it in a reasonable and responsible way? I'll give this question to you.
Well, I mean, first I'll say we haven't found, at least in the United States, a good regulatory framework for more traditional ML models. I think a lot of the work that John and his group at Chai are developing hopefully will be principles, regulatory principles. But when it comes to ChatGPT or LLMs, you know, some of those principles are hard to, they don't fit. For example, you know, John talked about LLMs being stochastic models. So how does reliability fit where every time you ask the same question, you will get a different answer? How does transparency fit if no one, perhaps outside of OpenAI, knows the data that was used to train GPT 3.5 or 4? How does explainability work where Sam Altman and the chief scientists at OpenAI have no idea how ChatGPT learns or thinks? And so I wonder if applying some of the traditional, you know, or evolving regulatory standards and principles for traditional supervised machine learning applications, are we like applying the rules of basketball to a game of baseball? Like just because we're using the same ball, do we need new regulatory approaches? Do we need new responsible AI frameworks that are specific to this, or can we retrofit existing ones? I think it's an open question. I mean, my hypothesis is it's going to be a significant retrofit, or we may need completely new ones altogether.
That points again to a piece of work that's yet to be done, right? In that area of that blurry gray area where we don't quite have the regulation in place yet, but where there is a lot of appetite and eagerness to explore. And it's also a question I would like briefly to give to all of you, maybe as a wrap-up. Richard Taggart in the panel discussion yesterday had a very pragmatic view on to, you know, we got to take risks. We have to explore, otherwise we're going to be left behind and we're not going to be able to tap into the potential that this technology brings. What would be your pragmatic advice to clinical practitioners, to the clinical workforce, on what to do right now to prepare for that transformation and to also leverage some of the opportunity for their work right now while staying on the safe side? Maybe, Nick, why don't you start and then we go.
Sure. Thanks, Stefan. I actually want to come back to something Farah said earlier, which is really about understanding what, some real simple fundamentals of what these models are and how they work. Because I think that little bit of education goes a long way. And to hark back to a previous point I made, I don't think the popular narrative helps this. I think that there's an incentive by people that make big foundational models to kind of cover this in a shroud of science fiction and not to get really clear on actually what is going on. And we've talked a fair bit about hallucinations, and that's probably the big problem that one of the obviously very, very prominent problems with these technologies. And I just think it's helpful as a tool to understanding these models is to understand what's actually going on when they hallucinate. So I might do that, and then the others can opine on the question, very important question that you asked. The mental model I will give you is, here's what happens when John's chair of cardiology gave that question to ChatGPT. ChatGPT's job, it is told, is to write something. And then in ChatGPT is a whole lot of weights that define the neural network, which has been learnt on data, and from those weights it draws the information. So it does not go back to a database like Google. There is no structured information that it is recalling from. It is simply recalling from its memory. So it would be the same as me grabbing any one of you and asking you to write a 500-word essay on the wine regions of Burgundy off the top of your head. You could get 500 words, and some of you would do relatively well. I might do pretty well. But even those who are well trained in it will have a whole lot of factual errors. The difference would be if I then gave you a textbook and said, you can use this as source material to write your essay. There's still a cognitive process that you're going through to create that essay, but you've got a grounding. Now that separation between grounding and what we generate at the moment is where the real rub is, and it's where a lot of the work in Google and OpenAI is going into, is how we get that grounding to be reliable. Because at the moment we can do it, we can reach back to databases and structured and known information and pull that into responses, but at the moment it's not reliably done. And so that is where I would say 70% of the effort currently is solving that specific problem. But I think to Farah's point, these mental models help because you don't really get told this in clear language in the general media about what these models are and what they do. So I hope that was helpful. And back to you, Stefan.
Farah,
Look, my advice is for clinicians, yes, go ahead and play with it, but my advice is more to government to invest in AI, particularly in health, because we see investment kind of across the board across all sectors, but I believe the needs in health are quite specific, and that needs investment.
John, you next. And we have your pragmatic.
So here's what Mayo Clinic is doing. We recognize there are some low-risk use cases, and those would be things like helping you respond to email, summarizing clinical data, help you with documentation. We'll work with those administrative low-risk use cases first, while we continue to learn about maybe the higher-risk possibilities. We will fine-tune both commercial and open-source foundational models to see if we can reduce hallucinations. And we'll work on retrieval augmented generation, this idea that, well, if you trust Mayo Clinic and the National Library of Medicine, and maybe there are extraordinary universities in Australia you trust, use search technology to retrieve documents, then ask ChatGPT, summarize these trusted documents. That's our strategy, and we think that's a reasonable course of action for the moment.
Thank you, John. 10 seconds, Johan, and 10 seconds, Daniel. I have an elevator pitch.
All right. One quick thing. The Uber line is now very close to the airport. It got in the back, and now it's really quickly. So I hope that is actually happening with this wave. So we're getting something closer, which was considered unsafe, but now everybody's using it, right? The second thing is keep a human in the loop. Keep the doctor in the loop. Let them do something. Because I draw circles in cardiology, right? The circles is already 4 years ago. AI is drawing it for me, but I supervise it. So that's the second thing. So supervised by a doctor who's aware and trained of the dangers. And like in physics, I get physics training of radiation, and I know the limitations of medications. So I train in these things, and radiation is a short training, but I know the basics, and I know what to prevent and what to protect my patient and myself from. So I think keep a human in the loop and try and gradually play around with a safety net, as James also is stating.
Wonderful.
And briefly, I would just say we have a mechanism of assessing safety and effectiveness. It's called prospective clinical trials. And so we are just talking about what it could do. Is it safe? We don't know. Does it work? We don't know. Well, we should actually test it. We should develop these tools, put them in clinical trials, prospectively in real-world settings, get smart people to work on this to demonstrate on whatever use case, does it work and what are the harms? And to use as benchmarks, we should, not perfection, but typical clinical practice, physicians, variability in care, etc. So I would love to see, as a part of government investment in actual generation of real evidence around these tools.
That's wonderful. So on all those notes, I think some of the key points that we can extract is how important it is to keep the human in the loop as we develop this, how excited we should be about the opportunities that it presents, especially when tying it into our real-world problems and daily frictions around efficiency and how we can use these technologies to ease some of that burden, how important it is to validate and make sure that what comes out of this delivers you real value, and how to possibly be less afraid of the risks, but be more capable of assessing and mitigating them. With that, Marie Curie said, there is nothing to be feared, but just more to be understood, that we may fear less. I think we all contributed to fearing less and the appetite to understand more. Thank you all very much here on the ground, in the audience, overseas, for contributing to that panel, for sharing your thoughts. I'm very much looking forward to discussing with all of you on stage, in the audience, and you in continued discussions what this development might bring and hold for all of us. Thank you very much.
Thank you.